process of C1. So you know that's found between the ramus of the mandible and the mastoid process. So we're right in there underneath the lobe of the ear. And then with that contact, we can test for rotation and lateral flexion. If you can turn this way just a little bit, okay? So, that's okay. So remember, when we're assessing the movement of C1, we always limit the movement of the head to about 15 or 20 degrees, because once we go beyond that point, we're going to be moving C2 and C3. So we want those to remain stationary. So when we test for the right side rotation, we're going to rotate just about that far. And when we're testing for lateral flexion, we have the same contact, and we're going to laterally flex like so, okay? So on rotation and on lateral flexion, if we have normal movement of C1 to C2, that distance between the examiner's thumb and the index finger should get slightly larger, okay? If that's not happening, then we've got the fixation of C1 to C2. Okay with the motion palpation? Coming back? Okay, so we'll put you on your back now. So we'll do the correction for the rotational fixation first, and then we'll do the one for the lateral flexion. Now, rotation, you already know how to do this because it's exactly the same as C2 to C7, like we did last week, okay? It's an index finger contact. The only difference is that on C1 now, we're going to be contacting the posterior arch, okay? Now, the posterior arch is found immediately below the rim of the occiput. So if you palpate the rim of the occiput and then you slide off into that soft tissue, the posterior arch of C1 is immediately below the rim of the occiput. So when you're putting your index finger contact on there to begin the manipulation, if your contact is correct, this portion of your finger should still be slightly touching the occiput. If you go below that, you're going to be on C2. So it's really, really close to the base of the occiput. So if my middle finger is the base of the occiput, then the posterior arch of C1 is right there. So when you take your index contact on the posterior arch, the top part of your finger will gently be touching the base of the occiput, okay? So it's really snug right up underneath the rim of the occiput. But then all the other things that we talked about last week for a rotary correction apply to C1 to C2. So you've got to reach over, slide onto your contact so you're taking out the skin slack, and then the flexion, lateral flexion and rotation is exactly the same as what we did last week. In the note package, all the stuff that we're talking about today, I think, is on the first 2 or 3 pages of the outline. Okay, so doctor starts at the head of the table. Number 1 rule in cervical adjusting: bring the head into flexion, and then we're going to hold it there. Okay, just like last week. With this finger, I'm going to reach way over to the other side, and I'm going to slide back on to the posterior arch. So now I'm holding the patient's head in flexion with this hand and these 3 fingers of this hand, and the index finger is on the posterior arch of C1. Okay, then same stuff as last week. A little bit of lateral flexion, and then as I start to rotate the patient's head, I'm coming around to the side of the table, getting down low, close into the patient, lock out the joint, and then the thrust would be in the direction of my thumb, superior oblique, okay? So I'm taking out the joint slack, and then once I've gone that far, the thrust is a short, fast flick of the wrist like that, okay? Try to remember to get your thumb up on the cheek of the patient, because if you keep your thumb down here, you might end up choking the patient. And when your thumb is down here, you can't keep your wrist straight. Remember, we talked about having a straight line from the tip of the finger right up to the elbow. If you put the thumb on the cheek of the patient, it will facilitate that. If you let the thumb go down underneath the patient's chin, your wrist is going to start doing this, okay? And then we lose that straight line. So we want to keep it straight like that, okay? So we're all set. Flex, laterally flex just to go through the points again. And then as you begin the rotation, bring yourself right around to the side of the table, get down low, come in close to the patient, take that last little bit of rotation out, keep your elbow close to your side, and then thrust like that, okay? And that's how you correct the C1 to C2 rotational fixation. Any questions on that? So basically it's a carbon copy of what we did last week, except now the index finger is on the posterior arch, right beneath the base of the occiput, okay? All right, C1 to C2 lateral flexion. Now, the only challenging thing about this particular manipulation is the contact point. The contact point will be on the tip of the transverse process of C1, but it's going to be a knuckle contact. So we're fitting this portion of the knuckle onto the tip of the transverse process. So we have to get this in between the ramus of the mandible and the mastoid process, okay? So there's a trick to doing this. It initially seems a little bit complicated and convoluted, but it will actually ensure that you get a very firm, accurate contact. So let's assume again that we have the fixation on the right-hand side. So the step here, we're going to bring the head into flexion again, but then I want you to turn the patient's head so that the fixated side is pointing up. Okay, so the fixation's on the right-hand side, so turn the patient's head so that the fixated side is facing up. Okay, so my contact point is going to be right here where my index finger is. So, first thing to do in order to get a firm contact, because it's very difficult to just come in and take your contact like this, because it's such a small space. And you run the risk of having your contact ending up on the ramus of the mandible or on the mastoid, but we want it to be right in there. So once you bring the head up and turn it into the position where the fixated side up, I want you to take your finger like this, like you're pointing at somebody, okay? And then point the finger away like that. And you're going to put the tip of your knuckle initially on the transverse process of C1. So it's going to be like this. So fixated side up, finger point this way, and then put the top of the knuckle on the transverse process of C1. Okay. So starting like this, I'm pointing away, and I'm putting the top of the knuckle on the transverse process, okay? Now, I can't manipulate like this because I'm going to sprain my wrist, okay? So what we're going to do after we take that initial contact is bring the patient's head back to neutral, and as I do that, I'm going to pivot my contact from here to here. So now the contact will end up on this portion of the knuckle, and it makes it much easier to do. So let's do this in slow motion. Okay, fixated side up. Point the finger away. Put the tip of the knuckle on the transverse process. Now I'm going to bring the head back to neutral and watch my hand, what I do with my hand. It's going to spin around like this. So I'm spinning it around like this, and then I'm opening my fingers up like that so that the fingers can help to support the occiput, and my contact has gone from here to here, and we're ready to go. So this is the most challenging part of the technique. The rest is easy, okay? So, up like so. Point the finger away. Put the top of the knuckle on the transverse process. Bring the patient's head back to neutral and pivot the hand around like that. Then, while maintaining the flexion, I do a little bit of rotation, and then I'm going to step to the side of the table, pull the head over into lateral flexion, and then the thrust will be a push across like that, okay? The other one was rotary for lateral flexion. It's a push. Still superior oblique, because we're still dealing with C1 to C2, and C1 to C2 has an articulation that points superior oblique, just like C2 to C7. So again, with this technique, it's exactly the same as we learned last week for C2 to C7, except now the contact point is the knuckle on the transverse process of C1 instead of on the articular pillar of C2 to C7. But it's still a superior oblique push. Okay? So we got C1 to C2 covered then. We've got the rotational technique with the index finger contact on the posterior arch. Then everything is exactly the same as we did last week. And then for lateral flexion, it's the knuckle contact on the transverse process with a superior oblique push technique. Lateral push. Okay? Any questions about C1 to C2? Okay, I think the most challenging thing that you'll have to do today is getting used to doing that knuckle contact on the TVP, because it's a very small space. But I think if you take a few extra seconds and do that little convoluted twisting procedure, it'll make a nice firm contact and it'll be accurate, and you won't be on the mastoid and you won't be on the ramus of the mandible. Okay? Any questions about that? Okay, now, C1 to occiput. We have to do that now, because C1 is a very unique vertebra, because the inferior articular facet of C1 slopes superior oblique, that we just talked about now. The top articular facet that articulates with the condyle of the occiput now, instead of sloping like this, slopes like this, so it goes inferior oblique. So, when we treat fixations of C1 to occiput, the only thing that's going to change from what I've just shown you now is one thing: the line of drive. Instead of being superior oblique, it's going to be inferior oblique to conform to the architecture of the C1 to occiput facet. Okay? So, it's very easy to do that. So, and then everything else is the same, okay? For the rotary technique, we're still going to have an index finger contact on the posterior arch. For the lateral flexion technique, we're still going to have the knuckle contact on TVP of C1. The only thing that changes is we're not going to be thrusting in this direction anymore. We're going to be thrusting in this direction. Then everything else is exactly the same, okay? Easy. Initially starts out looking complicated, but there's just a couple of things that change. So, C1, oh, we better do the motion palpation, just refresh that for you. So we'll come over here. Okay. Yeah, why don't you face out that way? Okay, remember the motion palpation for C1 to occiput? We're going to find the transverse process of C1. And then remember, we moved forward into the space between the transverse process and the ramus of the mandible. And in that small space, we can test for three things. We can test for flexion, extension, and rotation. Again, limiting the movement of the head to 15 or 20 degrees. Remember, on flexion, that small anterior space will